thank you to everyone for joining me today. Before we do actually start my presentation, I'd just like to introduce myself for anyone that I haven't met. My name is Allie Curran, and I'm currently a PGY1 clinical resident. I also am in charge of coordinating Grill, so you typically probably hear my voice in the background most weeks. But for my presentation today, we will be reviewing various hypersensitivity reactions and cross-reactivities within the NSAID, opioid, and sulfonamide classes. I chose this topic because while on rotation and during staffing, I have encountered numerous questions from providers regarding patient-specific allergies and whether or not that patient can safely receive another agent in the class. I chose these 3 specific classes because I feel like they are fairly common and many pharmacists will encounter them. I'd also like to thank Megan Wimmer, my content expert, for your help along the way. First and foremost, I have no actual or potential conflicts of interest I need to disclose. And I hope everyone learns a lot today throughout this presentation. However, I know there's going to be a lot of information that I present. So our main objectives are to be able to describe the various types of hypersensitivity reactions seen in the NSAID, opioid, and sulfonamide classes, identify the risk of allergic cross-reactivity between agents in these classes, and then outline appropriate management of the hypersensitivities discussed and talk about what these patients can safely receive in these situations. Before we get into the bulk of the presentation, I want to spend a little bit of time discussing background on patient allergy histories and the 4 types of immune reactions that we see. So a patient allergy history is an extremely important component of medication histories and should always be assessed. As pharmacists, we can play a vital role in verifying allergies and clarifying that these are really true allergies. We can spend time investigating the specific reactions that a patient has had to medications and if other medications in the same class have been tried. Some key items to address in an allergy history include, first, the nature of the reaction. So this is where we can determine if it is a true allergy or an intolerance or adverse effect. So thinking about a true allergy, we are thinking of anaphylaxis, shortness of breath, hives, angioedema, and other skin reactions. When we're thinking about an intolerance or adverse effect, this will, of course, depend on the medication that was taken, but some commonly seen include dizziness, drowsiness, nausea, and diarrhea. Next, we want to look at how the medication was taken, specifically by route. So by mouth, injection, inhalation, or if it was a topical. We want to look at the time to reaction after starting the medication. So this can range from acute in minutes or hours to more of a chronic late phase, which occurs over days, weeks, or months after the medication was initiated. Next, we want to look at when the reaction occurred. So it is, of course, optimal to get the exact time it occurred, but many patients will not often know this or remember this. So we can typically group it into 3 main time periods, thinking about less than 5 years ago, 5 to 10 years ago, or greater than 10 years ago. And this is important to think about because many patients will have allergies listed on their profile for long periods of time without reassessment. And oftentimes from experience, I will see older patients who have listed allergies from when they were a young child with an unknown reaction. And this can really muddy the waters on whether this is a true allergy or not. Next, looking at the outcome. So some important questions to think about and then also ask the patient, was medical attention required? If so, were they seen in the emergency department? Were they seen in a doctor's office, or did they get admitted to the hospital? And then also, was the medication stopped at that time by the doctor or continued after the reaction resolved? And last, thinking about similar medications that have been taken since the reaction. So it is important to decipher if the patient has retried the medication or if they have tolerated other medications in the class. And many patients will not be familiar or know what medications belong in different classes, but of course, this is where we step in as pharmacists. And we can also utilize chart review for this to help look back on previous office visits, admissions, and medication histories. And now that we have done our due diligence of investigating the patient's allergy history, let's talk about the 4 different types of immune reactions. So a drug hypersensitivity or a drug allergy in its simplest terms is an immune-mediated reaction to a drug. And these vary greatly in severity and in nature. And allergic drug hypersensitivities are traditionally classified into 4 different types. So we have type 1, which is IgE mediated. IgE causes mast cell degranulation, which releases histamine and other inflammatory markers. These can have a rapid onset occurring in minutes, but can also appear more late phase and occur up to 8 to 12 hours after administration. Symptoms can range from mild to more severe with angioedema and anaphylaxis. And treatment for these will depend on the reaction, but we can use epinephrine, bronchodilators, antihistamines, or steroids when clinically appropriate. Type 2 is our IgG and IgM mediated, where antibodies bind to cell antigens and cause phagocytosis or cytotoxicity that will lead to cell destruction. These are more delayed than type 1, usually beginning in hours to days after initiation, and they will typically present as drug-induced cytopenias and transfusion reactions. Type 3 is mediated by IgG and IgM, and this is where antibody antigen complexes will cause local inflammation and the recruitment of leukocytes. So these will typically be more delayed, occurring 1 to 3 weeks after beginning the drug. And these can present as a serum sickness-like reaction or systemic lupus, so presenting with fever, rash, and arthralgias. Our last type is type 4, which is mediated by T cells. So T cells are activated, leading to the recruitment of macrophages and release of inflammatory cytokines. These reactions are delayed, occurring weeks after therapy, and they can present as a benign rash or, in more severe cases, acute interstitial nephritis, stress, SJS, or toxic epidermal necrosis. All right, and now let's jump into talking about our first class of medications, our NSAIDs. So as we all know, NSAIDs, or non-steroidal anti-inflammatory drugs, are among the most commonly used medications on the market for multiple reasons, for their analgesic, anti-inflammatory, and antipyretic properties. These properties make them useful for treating a wide variety of conditions, ranging from muscle pain, arthritis, gout, and also as opioid-sparing agents in some acute pain cases. There are more than 15 different NSAIDs commercially available in the US, either by prescription or available over the counter. And when thinking about classification, NSAIDs are typically divided into groups and classified based on chemical structure and selectivity. So here I've just included a chart that classifies our common NSAIDs by chemical class or structure, and then also what type of COX inhibition it has. So either COX-1 or COX-2, and whether that is a strong or weak inhibition. And I will talk more about COX inhibition on this next slide, but this is just a great chart to have and refer back to. So the main mechanism of action is through inhibition of cyclooxygenase, or COX. Cyclooxygenase is required to convert arachidonic acid into thromboxanes, prostaglandins, and prostacyclines. And there are 2 main cyclooxygenase enzymes, COX-1 and COX-2. So COX-1 is regularly expressed in the body and it plays a role in maintaining GI mucosal lining, kidney function, and platelet aggregation. COX-2 is not regularly expressed in the body and is instead only expressed during an inflammatory response. As we know, there are a variety of adverse events reported with NSAID use, and oftentimes these are directly correlated with whether or not they are COX-1 or COX-2 inhibitors. So for example, when we think about ibuprofen, which is a strong COX-1 inhibitor, we think about common side effects being GI ulcers and increased risk of bleeding, just due to that COX-1 inhibition. All right, and now I want to introduce NHRs, or NSAID-induced hypersensitivity reactions. So NSAID-induced hypersensitivity reactions have been reported in 0.3 to 5.7% of the general population. Kind of a wide range there, and just differ depending on the population studied, the method of assessment, and the type of reaction. NHRs are thought to account for 20 to 30% of all drug-related reactions, placing them just behind antibiotic-associated reactions. So these are definitely seen in patients, and a reason for us as pharmacists of why we need to be familiar with them. Our highest risk patients are those with underlying chronic respiratory or skin conditions, and up to 30% of these patients will be affected by NHRs. Our classification and management is mainly guided by the European Academy of Allergy and Clinical Immunology, which published management guidelines in 2013. When looking at NHRs, there are two major classifications that we think about. So first, we have our non-immunologically mediated or non-allergic versus our immunologically mediated or allergic. These are then further divided by the presence of underlying disease and the timing of reactions, either acute or delayed. And I know this slide's a little busy and a lot to take in, but we will go through each of these reactions in the next few slides here. All right, so for our non-immunologically mediated NHRs, in terms of mechanism, these reactions are thought to occur due to the inhibition of COX-1. So COX-1 inhibition shifts that arachidonic acid pathway from the production of protective anti-inflammatory prostaglandins towards the production of pro-inflammatory mediators, eosinophils, and mast cells. This can then lead to an increased expression in bronchial muscles as well as endothelial and epithelial cells, which can lead to induction or exacerbation of respiratory and skin reactions. The onset is acute, occurring about 30 minutes to 4 hours after NSAID ingestion. And we have three main types of non-immunologically mediated NHRs. Our first being NSAID-exacerbated cutaneous disease, or NECD. These make up about 8% of NHRs, and these occur in patients having an underlying chronic disease of urticaria, or chronic spontaneous urticaria, also known as CSU. It has been reported that about 10 to 30% of all patients with CSU will experience an exacerbation of their underlying disease following NSAID consumption. Our symptoms for NECD are primarily limited to the dermis and subcutaneous layer of skin with no respiratory involvement. And these include wheals and angioedema. The magnitude of symptoms is dose dependent, and it is greater when the patient has currently active urticaria or CSU symptoms. Our second non-immunologically mediated NHR is NSAID-exacerbated respiratory disease, or NERD. These also make up approximately 8% of all NHR cases, with female patients and those with severe asthma having a higher prevalence rate. It occurs in patients with underlying lower or upper chronic respiratory diseases like asthma or rhinosinusitis. And symptoms for these are only respiratory in nature, including chest tightness, bronchospasm, rhinitis, and nasal congestion. Our last non-immunologically mediated NHR is NSAID-induced urticaria or angioedema. And these occur the most often, making up approximately 40% of NHRs. They occur in patients without an underlying chronic disease, and symptoms will typically include urticaria, angioedema. Patients often manifest with both simultaneously, but they can present with either one alone. All right, so now that we discussed the non-allergic reactions, let's talk about management. So these three reactions are known to be cross-reactive. So general recommendations include avoiding all strong COX-1 inhibitors, but there are other options for these patients. So selective COX-2 inhibitors such as meloxicam or celecoxib are generally well tolerated, but it still is ideal to initiate these when the patient is clinically supervised to make sure that they are tolerated. And our recommendations in favor for selective COX-2 inhibitors mostly come from retrospective reviews. In this retrospective review from Seelig et al., there were 309 patients with a prior documented NSAID hypersensitivity, and they underwent drug provocation tests or DPTs to confirm COX-2 tolerability. Patients received either celecoxib or meloxicam, and only 5.1% of patients had a positive reaction in the celecoxib group, and about 10% of patients in the meloxicam group had a positive reaction. So this shows us that allergic reactions to selective COX-2 inhibitors were fairly uncommon in patients with a previously documented NSAID hypersensitivity, and that over 90% of patients were able to tolerate a COX-2 inhibitor. So definitely an option to think about in these patients. All right, now jumping into our immunologically mediated NHRs. So the mechanism of action for these is either an IgE or T-cell mediated, and they occur in patients without an underlying chronic disease. There are two main types here. The first is a single NSAID-induced urticaria, angioedema, or anaphylaxis. This is that type 1 immune reaction mediated by IgE, and these reactions make up about 20% of all NHRs. They occur very acutely within seconds to minutes after ingestion, and symptoms include urticaria, angioedema, and anaphylaxis. Our second reaction is a single NSAID-induced delayed reaction, or SNIDR. This is T-cell mediated and a type 4 immune reaction. These are relatively uncommon, occurring and making up only about 5% of all NHRs. Onset for these are delayed, and symptoms typically include maculopapular rashes, contact dermatitis, and photosensitivity reactions. Other severe skin reactions such as SJS and toxic epidermal necrolysis or TEN can occur, but they are more rare. And it is important to note that these symptoms will vary on the specific NSAID agent. So for example, ibuprofen and naproxen are most frequently associated with maculopapular eruptions, while diclofenac and ketoprofen are more commonly associated with contact dermatitis. And then our selective COX-2 inhibitors are more associated with the severe skin reactions, such as SJS and TEN. Looking at the management for these, so these are not cross-reactive. So general recommendations for patients presenting with these just include strict avoidance of the culprit agent and agents with similar chemical structures. So I included this chart again here to remind you of the chemical classes and structures and agents that are in each. So just a great chart to reference to, but just avoiding that similar structure in the culprit agent. Other structures should be well tolerated in these patients. Our key takeaways here, NSAID hypersensitivities are common and many patients experience these. Pharmacists should be familiar with our 5 main types and their related management. And just to reiterate quickly, we can break it down into our 2 major groups. So non-immunologically mediated with our NECD, NERD, and NIUA. Those are cross-reactive, so you want to avoid all COX-1 inhibitors, but COX-2 is generally well tolerated. Our immunologically mediated are our SNIUAA and SNIDR. Sounds a little bit like alphabet soup, but these are not cross-reactive. You just need to avoid the culprit agent and structurally similar agents. All right, so next we will jump into opioids and talk about opioid hypersensitivities. When talking about opioids, it's important to understand their classification based on their chemical structures. And I don't want to spend too much time on this chart here, but I just want to point out that we have the 5 main classes of opioids. And for each of the classes, we see the common chemical structure, the common agents in that group, and then along the bottom, the cross-reactivity risk. So the first column on the left-hand side, that is our phenanthrines, and those are our typical opioids that we have many available oral and injectable forms. And this group is most likely to have cross-reactivities. So within the phenanthrine class, there is a possibility of decreased cross-reactivity with certain agents that lack the 6-hydroxyl group of morphine, and those are highlighted just with a single asterisk. So while those are all a probable cross-reactivity risk, some of those agents might be at a lower one just because they're missing a structural element. Next column to our right is our benzomorphans, which have a possible cross-reactivity risk, and then the other 3 structural classes have a low cross-reactivity risk. All right, and now I have a quiz question. So which of the following is considered a true allergy to morphine? I have A, itching, B, respiratory depression, C, angioedema, and D, tachycardia. And Shivani, I cannot see the chat, so if you could just let me know if anyone has anything in the chat, that would be great. Okay, perfect. I saw a C there, and just for time's sake, we'll go ahead. The correct answer is C, angioedema, which we will go over in these upcoming slides. But it is important to note that reported opioid allergies are super common, but less than 2% of opioid reactions are really considered true allergies. And more often than not, these allergies are really just adverse effects or intolerances, such as nausea, diarrhea, or pseudo-allergies, which we'll talk about shortly. All right, so here I want to highlight the frequency of drug allergy alerts in the EHR. So Topez et al. Investigated common drug allergy alerts occurring in the EHR and looked at the most common drug classes that were associated with these alerts. And overwhelmingly, the most commonly seen drug class was opioids, coming in at 48%, with the next class behind it being antibiotics at only 10%. So from this retrospective study, we can see that opioid allergies are documented for patients in their records, but are these really true allergies? Next, we'll start discussing the 3 different types of opioid allergies, which includes adverse drug reactions, pseudo-allergies, and then true allergies. So the first opioid allergy type is actually not really an allergy at all. It is adverse drug reactions. And so these are common, predictable, and dose-dependent effects from known pharmacological properties of the drug, but these will often be listed as an allergy for patients in their charts. Adverse effects make up about 80% of all adverse drug reactions, and some common adverse effects we see are GI related, so nausea, vomiting, diarrhea, or constipation, as well as drowsiness and dizziness. Some of our more severe that we think about are, of course, opioid dependence and then respiratory depression. In terms of management for adverse drug reactions, it's recommended to choose an alternative opioid agent based on adverse effect profile and then risk benefit to patient. I think it's also important to consider administration recommendations. So depending what the patient is experiencing, if they're having GI side effects, we can recommend taking with food. If they are experiencing drowsiness or dizziness, we can tell that patient to take it at night in an attempt to avoid these adverse drug reactions and adverse events. Next, we have pseudoallergies, which are a lot more commonly seen. So these are unpredictable, idiosyncratic hypersensitivity reactions with clinical features that are almost indistinguishable from true allergies. So symptoms include itching, flushing, and sweating, and are mainly cutaneous reactions there. The main difference between pseudoallergies and true allergies is the underlying mechanism of action. So pseudoallergies are mediated by endogenous histamine release by cutaneous mast cells, which is a non-immunological effect, whereas we know our true allergies are either IgE or T cell mediated. And that mechanism of histamine release explains why we see the symptoms that we see. Common culprits of pseudoallergies include codeine, morphine, and meperidine. In terms of management for pseudoallergies, we have multiple options. So first, we can try a non-opioid analgesic, such as acetaminophen or NSAIDs. We can avoid those common culprits that I mentioned, so thinking about codeine, morphine, and meperidine. We can switch to an opioid with less histamine release. So it's been noted that fentanyl and tramadol have been known to cause less of that release. And then finally, we can also give the opioid with an H1 or an H2 antagonist, such as cetirizine or famotidine, to help reduce histamine release. Lastly, we have our third type, which are true allergies. So these are extremely rare, as mentioned, occurring in less than 2% of patients. These are IgE or T cell mediated hypersensitivity reactions, and they are typically seen with prior exposure or repeat dosing of opioids. Our symptoms are what we expect from a true allergy, so angioedema, bronchospasm, urticaria, or anaphylaxis. And for management of true allergies, again, trying a non-opioid analgesic, such as acetaminophen or NSAIDs, or choose an opioid in a different chemical or structural class. So here, again, I included that chart, just showing our opioid classes by structure. So for example, if a patient has a true allergy to a phenanthrene, we can go ahead and use fentanyl, which is from a different structural class, and that will lower the risk of cross-reactivity and have a better chance of being tolerated. If choosing an opioid from another class, another structural class, patients should still be monitored closely for tolerability and any signs of allergic reaction. To finish our discussion on opioids, I wanted to include a retrospective cohort study that was conducted in hospitalized patients with a historically documented opioid allergy who received subsequent opioids. So this study's objective was to characterize the incidence of newly suspected IgE-mediated reactions, or IMRs, among patients with a chart-documented opioid allergy. The primary outcome was the incidence of allergic cross-reactivity between clinical and chemical opioid classes in patients with these historical IgE-mediated reactions. In terms of results, there were a total of 499 patients included in the study, And investigators found that having a historical IgE-mediated reaction was not significantly associated with cross-reactivity to either the same or any other opioid class, with cross-reactivity rates ranging from 0 to 6.7%. Of the historical allergies, 249 reactions, and about 50%, were determined to just be intolerances of the opioid. And 461, or almost 93% of patients, successfully tolerated readministration of opioids despite a chart-documented allergy, and then only 8 patients developed a possible IgE-mediated reaction. All right. So investigators concluded that the risk of new IgE-mediated reactions caused by opioids is low in patients with historically documented IgE-mediated reactions. And I think, as mentioned previously, recommended management at this time for a true allergic reaction is to try an opioid from another structural class. But I think this shows that it also may be an option to retry opioids and reassess allergies in these patients. Of note, over 50% of the documented allergies were found to be intolerances or adverse effects when investigated further. So I think, again, that just highlights a really important role that we can play as pharmacists to intervene and verify that these allergies listed on a patient's EHR are really true and not just an intolerance. Of course, if reassessing the allergy and retrialing, make sure that the patient is clinically monitored for any allergic reaction or tolerability. And our last class of medications will be our sulfonamides. And first, I want to just start with a patient case to have you guys think about while I discuss the sulfonamide class, and then we will discuss it at the end. So I have NB, who is a 67-year-old male with a past medical history of hypertension that had previously been well controlled on amlodipine 10 milligrams daily. While admitted, his blood pressures have been high and the hospitalist was considering adding chlorthalidone 12.5 milligrams daily. Patient's allergies include sulfamethoxazole, and when going to verify, you remember from pharmacy school that chlorthalidone also contains a sulfamoiety. So can NB safely receive chlorthalidone? And when talking about sulfonamide allergies, these are reported in 3 to 8% of the general population, so they are relatively common. Our most common reaction that we see with these is a rash. And sulfonamides in general are typically divided into 2 subsets. So first we have our sulfonamide antimicrobials, which includes sulfamethoxazole, sulfasalazine, and sulfapyridine. And then we also have our sulfonamide non-antimicrobials, which includes many other medications and drugs that we see. Of note, our COX-2 inhibitors, celecoxib and rofecoxib, our loop diuretics, sulfonylureas, and thiazide diuretics. So many others here that we see. Now, when addressing these allergies, it's important to think about the chemical structure of sulfonamides. So all sulfonamides contain an NH2SO2 moiety, seen there to your right. And sulfonamide antimicrobials also contain an aryl amine at the N4 position, and then a 5 or 6 membered nitrogen-containing ring at the N1 position. And these 2 additional groups that the sulfonamide antimicrobials contain are believed to be the primary determinant of allergy, rather than that NH2SO2 moiety that all sulfonamides contain. Thinking about our antimicrobial hypersensitivities, these appear in a variety of manifestations, but we typically will think of them as type 1 and then not type 1. So for type 1, these are our IgE, again with our symptoms of anaphylaxis, angioedema, and urticaria. And it's important to note that the NH2-SO2 moiety has not been found to be bound by IgE. So instead, it is really this heterocyclic ring that is at the N1 position that only the sulfonamide antibiotics have, which is recognized by IgE. And I just highlighted that at the bottom in red. Our non-type 1 reactions are typically associated with metabolites of the sulfonamide antimicrobial agents after they undergo either acetylation, glucuronidation, or hydroxylation. And stay with me for this next part because there's a little bit of organic chemistry flashbacks. But the N4 hydroxylated metabolite becomes what is called the nitroso compound or metabolite, which is in that diagram, it's the bottom right. And this nitroso compound can then undergo reduction utilizing glutathione, or it can become acetylated using the Na2 enzyme. And I just wanted to point that out because patients who are slow acetylator phenotypes or have glutathione deficiencies may actually be at a higher risk or may be predisposed to experience non-type 1 hypersensitivity reactions just due to their decreased ability to metabolize. And then this reactive nitroso compound can bind directly to T cells to elicit macular-papular eruptions, including SJS, and then other severe skin reactions. So that's kind of the organic chemistry behind why these occur. And thinking about the cross-reactivity between sulfonamide antimicrobials, just due to the structural similarities that all of these antimicrobials share. So again, that 5 to 6 membered nitrogen-containing ring, and then the aryl amine group on the N4 position. There is a high risk of cross-reactivity among these agents. So if a patient has an allergy to one sulfonamide antibiotic, others should typically be avoided. And here on the bottom, we can just see our structure color-coded with red, yellow, and blue that highlights that these share all those structures. For our non-antimicrobials, these do not undergo metabolism to the N4 hydroxylated metabolite and will not bind to IgE at the N1 position. So it is unlikely to cause cross-reactivity, even in patients who have experienced hypersensitivities to those sulfonamide antimicrobial agents. This means that patients can safely receive sulfonamide non-antimicrobials. And as you can see in our color-coded structures here, our non-antibiotics do not contain that nitrogen-containing ring or the aryl amine group. So they are less likely to have cross-reactivity, and they are safe in those patients. And after sharing that, I did want to include an interesting study that I found. So this was a large retrospective cohort study by Strom et al. And it included over 2,000 patients who received a sulfonamide antibiotic followed by a sulfonamide non-antibiotic within 60 days. And patients were divided into a study group, which included those who developed an allergic reaction following the administration of the sulfonamide antimicrobial, and then also the comparator group who did not develop an allergic reaction. The primary outcome was the development of an allergic reaction within 30 days after the first prescription for sulfonamide non-antimicrobial. And we have our results listed here. So patients in the study group with a history of a sulfonamide antimicrobial allergy were more likely to react to sulfonamide non-antimicrobials. And that was 9.9% versus 1.1%. They also found that patients in the study group with a history of a sulfonamide antimicrobial allergy were more likely to react to a penicillin antimicrobial, which was 14 versus 2%. So what do these results mean? Although a history of allergy to sulfonamide antibiotics is a marker of increased risk on later exposure to our non-antibiotics, the results suggest that this risk is not unique to the sulfonamide antibiotics. So patients with a history of hypersensitivity to sulfonamide antibiotics are at a greater risk for reactions to penicillins, and prescribers should understand that patients with a history of allergic reactions may be just at an increased risk overall to adverse events that are more allergic in nature. So there wasn't really a direct link to the sulfonamide antimicrobials, really just seeing that these patients are at a higher risk overall. And now going back to our patient case. So can NB safely receive chlorthalidone? The answer is perfect. Yes, Megan. Yes, Emily. Yes, so he has an allergy to sulfamethoxazole, and while chlorthalidone does contain that sulfamide, there is a low risk of cross-reactivity between the two due to those chemical structure differences. So he can safely receive that, and hopefully we can get his blood pressure down. All right, and now that is all I have for you guys today. I would be happy to take any questions. I know there was a lot of different information and a lot of different things covered. So if you have any questions,